In this segment, we will discuss vascular disorders of the bowel, including ischemic bowel disease and hemorrhoids. To begin the discussion, we will review the blood supply of the small intestine and colon. So the duodenum is supplied by the celiac artery and the superior mesenteric artery. The jejunum is supplied by the superior mesenteric artery, and the ileum is supplied by the SMA. In terms of the colonic blood supply, the ascending colon is supplied primarily by the SMA, the transverse colon supplied by the SMA, and the descending colon is supplied by the inferior mesenteric artery. The sigmoidal colon is also supplied by the IMA. Of note, the mesenteric border of the intestine has greater blood supply than the anti-mesenteric side. So ischemic damage to the bowel ranges from mucosal infarction to transmural infarction. Mucosal infarction does not extend past the muscularis mucosa. This is typically due to acute or chronic hypoperfusion of the bowel, as seen in cardiac failure, shock, dehydration, use of vasoconstrictive drugs, and the various vasculitides, including PAN, Annexelon purpura, Wegener's granulomatosis, or it can also be seen with mesenteric venous thrombosis. A mural infarction, on the other hand, involves both the mucosa and submucosa and is also due to either acute or chronic hypoperfusion. Transmural infarction and will involve all three layers and tends to be from acute vascular obstruction that results from either atherosclerosis, an aortic aneurysm, hypercoagulable states, oral contraceptive use, immobilization, or embolization of cardiac vegetations or aortic atheromas. In terms of epidemiology, ischemic bowel disease occurs in older people with coexisting cardiac or vascular disease. In terms of the pathogenesis, the intestinal response to ischemia occurs in two phases. The first phase consists of the initial hypoxic injury. In this phase, the epithelial cells are relatively resistant to the transient hypoxia, and most damage actually takes place in the second phase. And in the second phase, this is when there is reperfusion injury, which is initiated by restoration of blood flow. The severity of vascular compromise, the amount of time it takes to develop the compromise, and which vessels are affected will all determine the severity of damage. A general rule of thumb is that the intestine can tolerate slow progressive loss compared to acute compromise of blood supply. Another main principle is that the watershed zones are especially susceptible. Watershed zones receive dual blood supply from the most distal branches of two large arteries and are thus the least likely to receive sufficient blood, especially if you knock out one of those branches. In the colon, the splenic flexure is a watershed zone that is particularly susceptible to ischemic injury. To an extent, the sigmoid colon and rectum are other areas that are very susceptible. On examination, involvement is often segmental and patchy. The mucosa appears hemorrhagic and ulcerated. The bowel wall is also thickened from edema. On histology, there can be atrophy or necrosis with sloughing of the surface epithelium. And you will also see hyperproliferative crypts, and that's just from the intestine attempting to regenerate. Bacterial superinfection can lead to pseudomembrane formation, which would resemble a C. diff pseudomembranous colitis, which we'll touch on in a different lecture. Chronic ischemic disease, in contrast, will have fibrous scarring of the lamina propria, and you can get possible stricture formation as well. In acute infarction, patients will present with severe sudden abdominal pain, which is out of proportion to physical exam. That's going to be your characteristic trigger word in a test question, being out of proportion to physical exam. So they can have nausea, vomiting, bloody diarrhea, or even shock and sepsis as well. On exam, there tends to be decreased bowel sounds. In the case of chronic ischemia, patients often have intermittent episodes of bloody diarrhea. Ischemic bowel disease secondary to CMV infection can also incur, as CMV has a tropism for endothelial cells. In this case, clinically, it's going to be a patient that is immunosuppressed. You can also get radiation-induced vascular injury, producing changes similar to that of ischemic bowel disease when you get irradiation of the GI tract. Here, though, you will see these bizarre radiation fibroblasts in the stroma on histological exam. These patients will present with anorexia, ab pain, and a malabsorptive diarrhea in the case of acute radiation enteritis. In the case of chronic radiation enteritis, they tend to present as an inflammatory colitis instead, so you're going to get white blood cells in the stool. Necrotizing enterocolitis can result in transmural necrosis, and this is the most common acquired GI emergency of premature low birth weight neonates, and it typically occurs when you start oral feeding. Angiodysplasia is characterized by malformed submucosal mucosal vessels and occurs most commonly in the cecum or right side of the colon after the 6th decade, and it accounts for 20% of major episodes of lower intestinal bleeding. So the last topic we will discuss in this video is hemorrhoids. These are just dilated anal and perianal collateral vessels connecting the portal and caval venous systems in order to relieve venous pressure within the hemorrhoidal plexus. They are classified as either external or internal based on their location below or above the anal rectal line. So external hemorrhoids are located below the line and are due to dilation of the inferior hemorrhoidal plexus. Internal hemorrhoids are above the anorectal line and due to dilation of superior hemorrhoid plexus. Hemorrhoids can be found in 5% of the population and are normally found in those older than 30. They can arise from increased venous pressure, so common predisposing factors are constipation and the associated straining, venous stasis of pregnancy, or portal hypertension as in alcoholic cirrhosis. External hemorrhoids, morphologically, they can protrude and be observed as a rectal mass as seen in this picture. On histological exam, you will see dilated submucosal vessels with thin walls. Patients with external hemorrhoids often experience pain with bleeding. They experience this pain because those ones are supplied by cutaneous nerves, like the pudendal nerve, whereas internal hemorrhoids are traditionally not painful as they are above the dentate line and thus not innervated by the cutaneous nerves. Internal hemorrhoids, though, can cause pain if they prolapse or become incarcerated and strangulated. Both types, though, commonly present with rectal bleeding or bright red blood per rectum on digital rectal exam. The hemorrhoidal bleeding can be treated with sclerotherapy, rubber band ligation, infrared coagulation, or hemorrhoidectomy.